In this lecture, we'll be talking about at-risk pregnancy, and it covers the ATI chapters 7 through 10. The first thing we'll discuss is vaginal bleeding, and it could be caused by any of the conditions on this slide. Spontaneous abortion, another word for that is miscarriage. An ectopic pregnancy is where the pregnancy doesn't grow inside the uterine cavity. We'll talk about gestational trophoblastic disease and the other things that are listed on this slide as the presentation progresses. So the first one is a spontaneous abortion, and this is the loss of a pregnancy before 20 weeks of gestation. You can see the risk factors on the left-hand side of the slide. And for nursing care, we would want to assess bleeding and whether the individual passed any tissue. A lot of times women will save tissue and bring it with them when they come to the provider's office or to the emergency room. We'd want to provide emotional support. It doesn't matter how many weeks pregnant these women are. They've already bonded with the pregnancy, so it's important that we provide that emotional support. When families bond with the pregnancy and they lose a baby before 20 weeks through miscarriage, they are going to grieve, and they're going to grieve throughout the entire pregnancy, what it would have been, and the baby's first words, the first steps, the first day of kindergarten, etc. So these families are losing all of their hopes and dreams for this child. The provider may order labs like a CBC, clotting factors. HCG is human chorionic gonadotropin, which is a hormone of pregnancy. They may order an ultrasound, and they may do a sterile speculum exam that you as the nurse will assist with. Not every time, but some women require a DNC, dilatation and curettage, or a DNE, dilatation and evacuation, to remove the rest of the products of conception. Other times, women just require prostaglandins or oxytocin in order to pass the tissue. For client teaching, you would want to teach the client what to look for in regard to how much bleeding is normal. You would want to teach about any antibiotics that are prescribed. Coach them that they really shouldn't take any tub baths or have sexual intercourse for at least 2 weeks. That they could get pregnant right away, and they should probably see their provider and talk about birth control or fertility before they start trying again. An ectopic pregnancy, as I already mentioned, is when the fetus starts to grow outside the uterine cavity. It's abnormally implanted. So you can look at the risk factors on the left-hand side: a history of pelvic inflammatory disease or other sexually transmitted infections. That's a risk factor for ectopic pregnancy. Also, assisted reproduction, and in the coming weeks we'll be talking about fertility and infertility. If a woman had tubal surgery, like that she may have had another ectopic pregnancy and they just took out the segment that contained that fetus, or maybe she had a tubal ligation in the past and then she had a reanastomosis so that she could get pregnant again. And IUD use is also another risk factor. For nursing care, we're going to monitor and do vital signs, provide IV fluid and emotional support. Ectopic pregnancies aren't compatible with fetal development, so this is a termination of a pregnancy because most often the fetuses will implant in the fallopian tube, and if that tube ruptures with the fetus in it because the fetus is growing, it can cause quite a lot of blood loss and exsanguination of the mom. So these women most likely will require some kind of a surgery to remove the ectopic pregnancy. So they'll need good pre and post-op teaching and pre and post-op care. We'd want to provide lots and lots of emotional support and refer them to a pregnancy loss support group. Now, as I mentioned, that a lot of times these ectopic pregnancies are in the fallopian tubes. Sometimes they have to be, like the whole fallopian tube has to be removed. And that can really affect a woman's fertility because she only has one fallopian tube left. So that might in itself be quite a stressor, especially if a woman's undergoing some type of fertility treatment already. There is another treatment for ectopic pregnancy, and that would be the use of methotrexate in order to terminate the fetus, and then it would just be reabsorbed. The next topic is a gestational trophoblastic disease of pregnancy, or molar pregnancy. So you can see that there are risk factors. So a previous molar pregnancy would be a risk factor, as well as some age parameters there. I included what a molar pregnancy would look like. This basically is an overgrowth of placental tissue and no fetal tissue. Typically, these women will have a lot of pregnancy complaints, like lots of vomiting, hyperemesis. Their uterus will grow rapidly, so they are looking more pregnant than they should. They may start having some vaginal bleeding or discharge, brownish discharge, and sometimes they'll pass grape-like structures, tissue. They are the hallmarks of this molar pregnancy. If the pregnancy progresses after 24 weeks, you're likely to see gestational hypertension. You may see anemia related to the bleeding. They probably will have a high human chorionic gonadotropin or pregnancy test, so that quantitative value will be abnormally high. And when they do an ultrasound, they're not going to find a fetus. So this, again, is a pregnancy loss. This woman believed that she was pregnant. She had the symptoms of pregnancy. Her belly was getting big. She was sick to her stomach. And she has no fetus. So you will want to provide good emotional support and refer to pregnancy loss support groups. This woman needs to have a D&C or a D&E to remove that abnormal tissue, and we need to instruct the woman that they need follow-up HCG levels for at least a year, and they should avoid pregnancy for at least a year. So part of our nursing care is making sure that they understand that they need that year-long follow-up as well as good birth control for at least 1 year. Getting pregnant again before that 1 year puts them at a higher risk of cancer. The next complication of pregnancy is placenta previa, and that just means that the placenta is implanted in the lower uterus. And you can see some risk factors on the left-hand side. You would want to assess for bleeding. Now think about this. The placenta is in the lower uterus. It could be just the edge that's near the cervical opening. It could be that it's partially blocking the opening, or it can be completely blocking the opening. And that also means that the maternal side of the placenta is not adhered to the endometrium, and that's what can cause the bleeding. The hallmark symptom of a placenta previa is painless bleeding. So women, they'll be fine, and then all of a sudden they'll have vaginal bleeding, or they'll wake up in a pool of blood. And we would want to make sure that it's not membranes or ruptured membranes as well. But the bleeding is associated with no pain. We would want to do good fetal heart rate and uterine assessments, so hook them up to the fetal monitor, do some gentle palpation of the uterus. You should never do a vaginal exam on any woman who has vaginal bleeding if we don't know where it's coming from. And if you do, you could disturb more of that placenta previa and cause more bleeding. You will probably want to, or be ordered to, administer IV fluids for fluid replacement, and you'll probably give some medications like betamethasone. Betamethasone is a steroid. It's a glucocorticoid that is given very commonly to women who are preterm, that have a risk of delivering a preterm newborn, and that betamethasone crosses the placenta and helps mature the lungs in the fetus. For teaching, we would want to teach pelvic rest, which means nothing in the vagina. We don't want the woman to have sexual intercourse, even intercourse that doesn't involve genitalia, because we don't want that placenta to be disturbed. She may also be placed on bed rest or a modified bed rest so that she doesn't experience more bleeding. And then that last bullet point on the right-hand side is expectant management. That just means that we're going to watch and wait. As long as the mom and the fetus are both stable, we can just watch and wait. So this is just a graphic of what a placenta previa is. So the A picture is the placenta. It's a marginal placenta previa. It's low-lying. The picture B on the right-hand side is with that whole placenta covering that cervical os. When a baby has a placenta previa, the mom can't deliver vaginally. There's no way for this baby to come out. So moms that know they have a placenta previa need to have a C-section for delivery. And that might be a question on an exam. The next complication is abruptio placenta, or a placental abruption, and that just means there's a premature separation of the placenta from the maternal uterus before birth happens. And you can read through the risk factors on the left-hand side of the slide. Nursing care would be ongoing maternal and fetal assessment. Now, for an abruption, most likely you'll see vaginal bleeding, but it's associated with knife-like pain. There's also lots of uterine tenderness and guarding. When you palpate her abdomen, she's going to complain of pain. It's going to also feel board-like. You're not going to feel resting tone. It's not going to feel mushy. It's going to feel hard. On the fetal monitor, you may see a deteriorating fetal heart rate pattern because not all of that placental tissue is adhered to the maternal uterus, so oxygenation may be impaired. And you also will probably see very frequent contractions. So all of those things together make you think that it could be a placental abruption. You may want to do fundal height monitoring, especially if they're having all of these symptoms and not a whole lot of vaginal bleeding. The blood could be collecting inside the uterus, causing a rise in fundal height. Depending on how severe the abruption is, we may need to prepare for an imminent birth, so that we should notify the neonatal team and the obstetrical team to let them know that what's happening, and for the neonatal team that this baby could be born and need resuscitation. For small abruptions, when mom and baby are both stable, we usually see expectant management, so watching and waiting. And then this is all abnormal. Moms are probably really scared. They're afraid for the well-being of their fetus and for their own well-being. So providing that emotional support for these patients. And this is what a placental abruption looks like. So that picture on the extreme left-hand side is a concealed hemorrhage, and a lot of that placental tissue is not adhering to the uterine wall. So for this one, we're probably not going to see any vaginal bleeding. This is very rare. I actually had a patient like this, and the provider didn't believe me when I said that I thought she was having an abruption, because the woman did not have any vaginal bleeding, and yet she had quite a profound abruption. The center picture is a partial abruption, where just you can see the one little edge is torn away from the uterine wall. So you'll see some vaginal bleeding, and then it doesn't have to be associated with rupture of membranes, but it can be. And then the picture on the the right-hand side is a complete abruption, when there's no placental tissue adhering to the uterine wall. And that means the baby's not getting any oxygen or gas exchange, and this is a big emergency. The next thing that I want you to be aware of, but I won't test on, is vasa previa, and that just means that the umbilical vessels develop in the fetal membranes, and they could be over top of the cervical os. So those types of vasa previa, they're just words on the left-hand side. I'm not going to test on those. Usually this is identified on fetal ultrasound, and then there's a plan for delivery, like a C-section, because if these vessels tear, the baby will bleed out, and that's a big emergency. So we would provide pre and post-op nursing care if the mom had a diagnosis of vasa previa. And these are just pictures for your knowledge. Again, I am not planning on testing any of this. If you look at the picture on the right-hand side of the screen, you'll see that those vessels are coming in front of the baby's head, and that's also a vasa previa. Infections in pregnancy. So I promised in the newborn complications that we'd run into this in a future slide deck, and on this slide we'll see those torch infections. Other infections in pregnancy could be HIV, Group B strep, and a lot of different sexually transmitted infections. So to start off with, human immunodeficiency virus, the virus that causes AIDS. You can see the risk factors on the left-hand side. So when you're taking a good history for the mom, you'll want to just, make sure that you identify those women that are at risk for HIV. These women need counseling, and they need instructions to take their meds. Some women enter pregnancy and don't know that they have HIV. So this is a good opportunity to get them started on their meds to help improve their quality of life, as well as decrease their complications in the future. They need to be counseled to take those meds the way they're prescribed, so that they can keep those viral loads low. We want to make sure that they're adequately immunized, because they're already compromised due to the HIV virus. We will definitely want to teach them about safe sex and let them know that they can transmit the virus to other individuals if they're unprotected. After the baby is born, we want to make sure that we wear gloves when we care for the baby, and we want to make sure that we bathe the newborn immediately after birth, especially before we administer any vaccines or vitamin K by puncturing the skin. So we want to wash off the maternal secretions before we administer those injections. And then it's really important that we counsel these women not to breastfeed, because the HIV virus is present in breast milk, and we don't want that vertical transmission to happen to the newborn. So torch, there are multiple risk factors. You can look them up. I'm not going to test on them. Moms that have torch infections put their babies at risk for neonatal complications. So we want to monitor for fetal well-being. We want to provide appropriate teaching for medications, and also teach about safe sex and provide emotional support. Sometimes knowing that you have one of these infections is quite a devastating experience. I want to spend a little time on Group B strep. We've already touched on it in previous lectures. Typically nowadays, women are cultured for Group B strep around 36 weeks. So they'll do a perineal anal swab and send it to the lab and test for Group B strep. Now strep is a normal skin flora. And most people have some Group B strep on their skin. However, some women colonize it, and they're the ones that we want to identify so we can treat during labor to prevent that transmission of that Group B strep bacteria to the newborn and cause sepsis and worse. Also, risk factors could be prolonged rupture of membranes, preterm delivery, because we don't know whether moms are positive or negative. Internal monitoring can place the baby at risk for Group B strep. And we want to also be vigilant for intrapartum fevers. So usually when we identify a woman that's positive for Group B strep, the provider will order penicillin or other antibiotics if they're penicillin allergic to be administered during labor. And then the newborn should be assessed for any kind of newborn infection for 48 hours just to make sure everything's okay. Chlamydia. The risk factors are multiple sex partners and unprotected sex. The important thing about these sexually transmitted diseases or infections, is that we want to make sure that we instruct the proper administration of the antibiotic. We want to treat all the exposed partners. We want to teach the patient safe sex. And then, especially for chlamydia, we want to make sure that those pregnant clients are retested after completing antibiotic therapy. And this is one of the infections, one of the reasons we administer erythromycin to the infant to help prevent blindness due to chlamydia infection of the newborn's eyes. This slide, gonorrhea, is also pretty much like the previous slide. So I really don't have anything to add. Syphilis. Risk factors are on the left. They're pretty similar to the previous. The important thing here is that syphilis is making a comeback, so it's really important that we screen for syphilis and get women treatment during pregnancy to help prevent congenital syphilis, which can be devastating in the newborn. Human papillomavirus is another sexually transmitted infection. So in order to prevent this, we would want to encourage the HPV vaccine. We would want to do that around age 12, so we'd encourage the parent of an adolescent girl and boy to be vaccinated with the HPV vaccine to help prevent human papillomavirus in the future. And human papillomavirus has also been associated with cervical cancer. So not only receiving this vaccine will protect against this virus, but also help prevent cervical cancer. And that's another reason for men to get it, so they don't transmit this virus to their female sexual partners. Trichomonas, I am not going to say anything more about this. This is just another sexually transmitted disease that some women get. Bacterial vaginosis is pretty common during pregnancy. It's really not a sexually transmitted infection. It is recommended that sex partners are treated, but usually they just need some metronidazole. And when patients take metronidazole, they should avoid drinking alcohol because it can cause nausea and vomiting. Candidiasis, or yeast infection. So you can see that one of the risk factors is pregnancy, also diabetes, oral contraceptives, and lots of other things. We do want to instruct in the appropriate treatment, and also tell them that yeast likes to grow in dark, moist places, which that's what the vagina is. So we would want to teach that maybe using some cotton underwear to allow that area to breathe more, some more air circulation, and avoiding that really tight-fitting clothes. In the summertime, making sure that your baby get out of that wet bathing suit. Women should avoid douching. Sometimes it can help if the woman's vaginal flora is restored, so probiotics, yogurt, but more often than not, they'll require some kind of either fluconazole, an oral dose, or some vaginal creams to cure this. On to cervical insufficiency, and it used to be called incompetent cervix. So this just means a premature cervical dilation, and it could result in the preterm delivery of a fetus. A lot of times women don't know they have this until they're delivering their preterm fetus without a whole lot of notice, like no contractions, very little pain. The risk factors are listed on the left-hand side. DES exposure is diethylstilbestrol, and it was a medication that was given to pregnant women back in the 60s and 70s, I believe, and this actually caused congenital anomalies for the female fetus. So we're not seeing a whole lot of DES exposure nowadays. Nursing care, if the woman comes in and complains of pressure in their vagina or their pelvis, they might come in, and if they are found to be dilated, sometimes the membranes are starting to prolapse. They're placed on bed rest, sometimes in Trendelenburg position, so head tilted down to help reduce those membranes back up into the uterus. We would want to do frequent vital signs, fetal heart rates, contractions, provide hydration. These women also should be on pelvic rest. We do not want them to contract because then that could cause more cervical dilatation. A lot of times before 24 weeks, if this happens, women will undergo a procedure called cervical cerclage, and that's when there's a purse string suture placed around the cervical opening and drawn shut. Then it'll be removed at about 37 weeks, and the woman can then go into natural labor because she's at term. So if the cervical opening is sutured closed, we need to monitor for contractions. We don't want her to have contractions because there's nowhere for this baby to go. If she has contractions with the cervical cerclage in, that puts her at risk for uterine rupture. And we would want to make sure that we explain that she would need to report contractions to her provider as soon as she notices them. Next, we'll talk about hyperemesis gravidarum, which is just a lot of vomiting in pregnancy, more than you would expect. So normally, very commonly, women in early pregnancy in that first trimester will experience some nausea and vomiting, and that's just due to some interplay of hormones, and we'll talk about more about that when we talk about antepartum care or prenatal care. So you can read through the risk factors on the left-hand side of the screen. Please note that multiple pregnancy is there because they have more hormones. I already talked about that hydatidiform mole or gestational trophoblastic disease. So those are things that should come to mind when a woman is complaining of lots and lots of vomiting during their pregnancy. But other women can have a hyperemesis and have a singleton pregnancy. We would just need to treat them. So nursing care would be vital signs. I&O, we'd want to monitor their weight, also do a good comprehensive head-to-toe assessment. We want to keep them NPO until they're not vomiting again, kind of like doing some gut rest, and then advance as tolerated, AAT. So start real slow, clear liquids, maybe some dry crackers or toast. We may have to provide some IV hydration and some antiemetics. Zofran, sometimes Reglan or metoclopramide is used. Some providers order B6 and doxylamine, which has been very effective. And then in very extreme cases, parenteral nutrition would be needed. Next is iron deficiency anemia, and you can see the risk factors on the left-hand side of the screen. For nursing care, we'd want to teach the woman how to increase their iron. So teaching them iron-rich foods, teach them how to take oral supplements safely and what the side effects are. So usually black stools are a side effect, constipation. So we would want to also teach how to avoid constipation by increasing their fluid intake, their intake of fiber, and getting some exercise. Sometimes parenteral iron therapy is required, and that's an iron infusion. They would go to the hospital infusion center to receive that. And every once in a while, some women will require a blood transfusion for profound iron deficiency anemia. Next, we'll talk about gestational diabetes. So when we talked about hypoglycemia in the newborn, we kind of touched on some of these principles. So gestational diabetes is impaired glucose tolerance along with some insulin resistance, and you'll get more of that in level 3. So we're going to keep it really high level for the purposes of this course. So you can read through the risk factors on the left-hand side of the slide, just like type 2 diabetes in adults, obesity, hypertension, family history. They're all risk factors. And these have a risk to the fetus. Having gestational diabetes can result in a baby with macrosomia, so a big baby that could result in birth trauma, and then neonatal hypoglycemia. Moms also can have complications as a result of gestational diabetes, and these include infections, hydramnios or polyhydramnios, too much amniotic fluid, ketoacidosis, and they can also have hypo and hyperglycemia. When you are treating a patient or caring for a patient with gestational diabetes, you can expect that the provider will probably order an oral glucose tolerance test. Now, typically, pregnant women around 28 weeks are ordered an oral glucose tolerance test. If their results are below a certain threshold, and I believe it's around 140, but I'm not going to test on that number, then they'll have to do a 1 to 3 hour glucose tolerance test. So these glucose tolerance tests they're given a 50-gram carb load, and it's like soda syrup without the bubbles that they have to drink. They go in and first they have a fasting done, then they're dosed with that 50-gram load, and then their blood is tested at 1, 2, and 3 hour intervals for the 3-hour glucose tolerance test. We also want to keep an eye on the ketones in the urine, and women with gestational diabetes, they will have non-stress tests and biophysical profiles and may need an amniocentesis at the end of pregnancy. And we'll get more into those tests, I believe, in the next lecture when we do prenatal care. So, what's really, really important with these women are maintaining really tight control. So we want them to have pretty much a normal glucose. So they need to monitor their blood glucose levels, and it's really important for them to maintain a log. So one of the first things and the highest priority for the nurse to do is to teach them how to test their blood and how to maintain the log. After that, we would also want to provide a referral to the dietitian so that they can understand and learn how to properly take care of their diet. Sometimes providers need to order oral or parenteral medication. So insulin. We would want to monitor for maternal well-being, and we also want to monitor fetal well-being. So because we know that gestational diabetes causes risks to the fetus, we would counsel the woman to do daily kick counts. And that's just the mom laying down on her side, putting her hands on her belly, and counting how many times the babies move within an hour. And if they get to, some sources say 4, some say 10, within an hour, then we can be assured that the baby's doing okay. And then again, testing with that non-stress test and biophysical profile. Next, we're going to spend quite a bit of time talking about the gestational hypertension spectrum. So on the slide, from top to bottom, goes from the least serious to the most serious on this spectrum. So gestational hypertension occurs after 20 weeks and usually resolves by 12 weeks postpartum. And it's just an abnormal elevation in blood pressure with no other symptoms. Next, we come to preeclampsia, and this is associated with proteinuria. So women are going to have protein in their urine that's at a +1 or more. After that, if we see preeclampsia with severe features, we're seeing quite a profound elevation in blood pressure. So over 160 systolic, over 110 diastolic, and or the evidence of some end organ damage. So the end organs in this case could be the central nervous system, which would manifest as headaches or visual disturbances, as well as hyperreflexia. It could be the renal system, and we're going to see proteinuria of +1 or more. And it also could be the liver. So when those end organs appear to be damaged, then that patient is said to have preeclampsia with severe features. Now, the way we would know if the liver was involved is by monitoring liver enzymes. So you'll see the provider order an ALT, AST, LD. You'll probably see a uric acid, which is an indication of renal involvement. Moving to eclampsia, the only difference between pre-eclampsia and eclampsia is the onset of seizure activity. So usually you won't see a woman that just has preeclampsia without severe features move right to eclampsia, more likely you'll see a woman with evidence of end organ damage and a high blood pressure that leads to seizure activity. And that central nervous system, that end organ, is affected. The last stop on this gestational hypertension spectrum is HELP syndrome. And HELP is an abbreviation for hemolysis, elevated liver enzymes, and low platelets. So a woman may or may not have high blood pressure with HELP syndrome, but has that hemolysis, elevated liver enzymes, and low platelets. So you can read the risk factors on the left-hand side. Note that multiple gestation, obesity, chronic hypertension, family history, all are risk factors. And we're seeing more and more women with these risk factors in the delivering units nowadays. For nursing care, the biggest thing we want to make sure that we do is take an accurate blood pressure. And when I say that, you learned how to do accurate blood pressure monitoring in level 1. I know you did. So you have to remember that you need the right size cuff, and you have to apply the cuff in the correct manner, in the correct spot on the arm. Have them sit up with their feet on the floor, their arm at the cuff at the level of their heart, their arm supported, and so on. So you want to make sure that you take an accurate blood pressure. If the blood pressure cuff is too big, then you're going to get an abnormally low reading. If the blood pressure cuff is too small, you're going to get an abnormally high reading. You need an accurate blood pressure. Other assessments include urine dip for protein, assessing edema. Now, this isn't actually a defining finding for preeclampsia, but a lot of times you'll see edema, dependent edema in pregnant women. Women with preeclampsia also have some edema in their hands and in their face. So periorbital around their eyes. These now we don't usually see these patients before they come in sick like that. So I usually ask the birthing partner, it's like, well, how does she look? Like, is this her normal look? Or she looks puffy around the eyes to me. Is that normal for her? I already mentioned visual changes. Another symptom of liver involvement would be right upper quadrant or epigastric pain, nausea, and vomiting. You may also hear decreased breath sounds or crackles in the bases, and that's part of that edema that's happening in the woman's body, that third spacing of fluid. I already mentioned seizures, and in some extreme end organ damage of the liver, you may see some jaundice. Now, even if a woman is diagnosed with some high blood pressure, we want to make sure that we do teach all of these warning signs to these women so that they know that they need to call the doctor, their provider, if they're having any visual changes, any headaches that aren't relieved with Tylenol, right upper quadrant pain, nausea, vomiting. These are important to teach. So risks to the fetus. I know you haven't had a lot of information about hypertension, but this gestational hypertension is really narrowing of the vessels and narrowing of the spiral arteries in the uterus. And that's really what is causing this high blood pressure in the moms. So if these spiral arteries are not dilating properly and they're constricted, then there's not as much oxygen or nutrients getting to the fetus, and that can result in IUGR, intrauterine growth restriction, and small for gestational age babies. You can also see placental abruptions due to the high blood pressure. Babies are born prematurely because of the HELP syndrome or preeclampsia with severe features. Also can result in hypoxia and stillborn. Maternal complications include eclampsia, seizure activity, pulmonary edema. So these women have fluid in their lungs. They're going to complain that they are short of breath, that they can't get their breath. Women can also have a myocardial infarction, a heart attack, a stroke. DIC you'll learn about in level 4, disseminated intravascular coagulopathy. I'm not going to test on that. They are also at risk for postpartum hemorrhage, PPH, and death. So we need to be very vigilant about these patients on the gestational hypertension spectrum so that they don't experience these complications. Medications for preeclampsia with severe features and help include methyldopa. It used to be more widely used. I haven't seen it in quite some time. Labetalol and nifedipine I had you profile this week. Hydralazine is another antihypertensive. And I want to take a few minutes to talk about magnesium sulfate. This is an IV infusion that's given to the woman to decrease their CNS irritability. So we want to prevent seizures, and that's why we give magnesium sulfate to these women with preeclampsia. What magnesium sulfate also does is it relaxes the vessels, the blood vessels. So you may see a decrease in blood pressure after the woman starts getting this infusion. But the real reason that we want to give this is to decrease the irritability of the central nervous system to prevent seizures. So typically magnesium sulfate is given in a bolus at first, 4 to 6 grams over 20 to 30 minutes, and then they're put on an infusion basal rate of about 2 grams per hour. During this infusion, we need to monitor for magnesium toxicity, and that would be whether the patient gets bradypneic, which means their breathing is very slow, slower than normal, so 12 or less, or she may stop breathing. We'd also want to reassess their deep tendon reflexes very often, at least hourly. And if typically preeclamptic patients with severe features have very brisk reflexes. So when you do their patellar reflexes, they're at least a +3 or a +4. So you'll want to keep an eye and assess those deep tendon reflexes, and they should never be absent. If their deep tendon reflexes were hyperreflexic before they started MAG and now they're absent, it could be an indication of magnesium toxicity. If you discover that, the first thing, the highest priority thing that you'll want to do is stop the infusion. Magnesium is usually very easily cleared. It's usually cleared through the kidneys. And it's usually quickly cleared. So stop the infusion. Many times in the order set for magnesium sulfate is an order for calcium gluconate to be given if needed for magnesium toxicity. So after you shut off the MAG infusion, you'd want to contact the provider, let them know what's going on, and then if they want the calcium gluconate given, then you would give it. Also with magnesium, you want to keep an eye on their output. So typically with a patient with preeclampsia, you're going to see that their urine output, when they start to go bad, their urine output starts to decrease. And you need to let the provider know if their urine output is less than 30 milliliters in an hour. These severely ill, critically ill patients are on hourly isonos. So you're going to be emptying the Foley very frequently, and you need to let the physician know when the patient's output is inadequate. Remember that I said that magnesium sulfate is cleared through the kidneys. So when their urinary output is decreasing, they're not clearing as much MAG, and they're at higher risk for toxicity. Heading over to the right-hand side of the slide, you want to continually assess maternal and fetal status, and you want to monitor for headache, vision changes, that epigastric pain, nausea, vomiting, deep tendon reflexes, and clonus. Clonus is just another indication of a hyperstimulated central nervous system. The last thing that I want to address on this slide is teaching and emotional support. Patients that are receiving magnesium sulfate, they're sick, and then we're giving them a medication that makes them feel like garbage. So it does cause a headache. Many patients that I've had on magnesium complain of a headache. So we don't know whether it's a headache related to preeclampsia or related to magnesium. They also feel very hot and flushed. Their skin is flushed. It's red and hot, and that's due to the vasodilation that is caused by the magnesium. So provide comfort measures. You might need to give them a cold, wet cloth to put on their forehead or to wipe down their arms and legs. Give them Tylenol as ordered for the headache. They're scared. Something different is happening with them. Give them lots of information. Let them vent their feelings and give the families emotional support as well. Moving on to preterm labor. This is regular uterine contractions that cause cervical change before 37 weeks. And you can look at those risk factors on the left-hand side of the slide. And the risks to the fetus are obviously prematurity, small for gestational age, hypoxia, and stillborn. So the things that we would do, some labs that you might see are doing an FFN, which is a fetal fibronectin. This is a vaginal swab that the provider might take and send to the lab, and it's looking for a specific hormone that is present. If there's a delivery, if it's positive, that means there's a good chance for delivery within 2 weeks. So if it's negative, it means there's really a very low probability of the baby being born in 2 weeks. The provider may also collect cervical and vaginal cultures to look for an infection, do a CBC, a UA to look for a urinary tract infection. They may do an ultrasound and look for cervical length to determine whether there's any cervical change. And then the last two are the non-stress test and the biophysical profile, which we'll get to next week. Medications for preterm labor include antibiotics if it's determined that they have an infection. Sometimes in some nursing units they give magnesium sulfate because it does have tocolytic properties. It is a smooth muscle relaxant, and the uterus is a smooth muscle. But it's not evidence-based practice anymore. However, some places still use it. Terbutaline we talked about earlier, that is also a tocolytic. Nifedipine can be used. It's a calcium channel blocker. So it also inhibits smooth muscle contraction early in pregnancy before 32 weeks. Some providers order indomethacin, which is a prostaglandin inhibitor. And if you remember when we talked about induction of labor and cervical ripening, we use prostaglandins. So indomethacin, a prostaglandin inhibitor, is given to pregnant women of less than 32 weeks if they're in preterm labor. Given after that time, there's a chance of the ductus closing prematurely, and the ductus arteriosus is one of those shunts in fetal circulation that we want to stay open until after the baby's born. The last one there is betamethasone, and we discussed that a little bit, but that's a glucocorticoid given IM to a mother if they believe that she's going to deliver preterm. And that helps to decrease inflammation and also helps mature the baby's lungs, produce surfactant. For nursing care, these women are usually placed on a modified bed rest, so like bed rest with bathroom privileges. We don't see a whole lot of complete bed rest anymore because of the increased risk for blood clots. We'd want to monitor for contractions and of course fetal heart rate, report any contractions that the patient is having. We should palpate for the strength of those contractions as well. And then for teaching, having the woman report any kind of change in her uterine activity or fetal activity, and then teach about medication administration and side effects. The next thing we'll talk about is premature rupture of membranes or preterm premature rupture of membranes, and you can throw in another P that would be preterm premature prolonged rupture of membranes. You'll probably hear some of them, all of them on the clinical unit. Your risk factors again are on the left-hand side of the screen. Your risks to the fetus are that prolapsed umbilical cord, prematurity, small for gestational age, could be a congenital infection, and stillborn. Labs and diagnostics, we talked about nitrazine paper in one of the first lectures, Ferning, Amnisure. Also, the provider may want to collect vaginal cultures, and then also a CBC and other admission labs to see if there's any infection brewing. Worth mentioning here, that last bullet point, an amniocentesis for an LS ratio, and that's just a measure of fetal lung maturity. Just something to note, it could appear on your NCLEX. I'm not going to test on that. Medications include antibiotics, and they're usually prophylactic, so we want to prevent a woman from getting an infection. If the woman is not contracting, we want to keep her pregnant for as long as possible. If we can keep her pregnant till she's 34 completed weeks, then we would induce the labor. But to keep the infection or to help prevent infection, more likely the provider will order antibiotics, also betamethasone because of the prematurity. And they may or may not order magnesium sulfate for neuroprotection. Another thing that magnesium sulfate does for the fetus is it helps protect against intraventricular hemorrhage. So our nursing care for that patient with premature rupture of membranes includes electronic fetal monitoring, and we definitely will want to be aware of variable decelerations. Those membranes are ruptured, that fluid continues to leak out, so there's less and less of a cushion for that umbilical cord. We'd also want to monitor for contractions and let the provider know if the client is starting to have regular contractions. We want to avoid or limit cervical or vaginal exams because every time we go in there to do an assessment, we're increasing the risk of infection of that mom, that chorioamnionitis or fetal infection. We would want to teach the patient about limited activity. So again, modified bed rest. She should be on pelvic rest, nothing up inside the vagina. Now, more likely than not, women with premature rupture of membranes, they're going to be in the hospital until they deliver for as many weeks as it takes. They should not be taking a tub bath because that fluid from the tub can get up in there and cause infection. Some providers want their patients to do pericare, so we would teach them how to keep that perineal area clean. As nurses, we would want to also assess for infection. They would be on Q4-hour vital signs. We want to assess for uterine tenderness, so if there's an infection starting, their uterus would become tender. And we'd want the patient to let us know if they start smelling a foul smell in their vaginal discharge. That also could be an indication of an infection. Next we'll talk about twins, triplets, and higher order multiples. So you can read about the risk factors on the left-hand side. We're seeing more multi-fetal pregnancies now because there's more reproductive technology out there. So one of the biggest risks for multiple pregnancy is prematurity. You've got more babies in there and there's not as much room. So these babies could come early. They also could have intrauterine growth restriction and discordant growth. One could be growing a lot faster or a lot slower than the other one or ones. There's a higher risk of congenital anomalies. They have a higher risk of cerebral palsy. And twin-to-twin transfusion is when there's some abnormal communication between the placentas, and that would result in a discordant growth. One baby would grow bigger and the other one would not grow as quickly. So the risks to the mom, we talked about earlier, hyperemesis, cardiovascular strain. So the human body really was only designed to carry one baby at a time. But every once in a while we have twins and triplets and higher order multiples that happen, and that does place extra strain on the cardiovascular system. The woman is also at risk for anemia, so she needs to take more iron in order to supply that to the fetuses. It could result in anemia of the mom because the babies are going to take it whether the mom is being supplemented or not. Spontaneous abortion, SAB, gestational diabetes mellitus, gestational hypertension, placenta previa, and also postpartum hemorrhage due to overdistension of the uterus. So your diagnostics are usually it's discovered on ultrasound, and we would follow up with biophysical profile and non-stress testing toward the late end of the pregnancy. We would want to teach about complications. Their activity level should be about the same until they hit about 5 months gestation, and then they really do need to rest more. They have added nutrition needs because they're growing more than one baby. And we'd also want to provide anticipatory guidance. They have to prepare for more than one baby coming home. So we would want to make sure that they have appropriate follow-up care after the babies are born. So this concludes our pregnancy complications lecture. If you have any questions, don't hesitate to reach out.